Dr. Rosen, how many young people are you seeing right now, and is breast cancer on the rise with young women and young men?
Well, regrettably, cancer is on the rise in young men and women across the world. What we're seeing is cancers that we typically saw in the 50s and 60s and beyond, we're now seeing in people in their 40s and sometimes even in their 30s. And regrettably, for whatever reason that people are getting cancer related to our environment, we're seeing it at earlier ages.
How early?
For breast cancer in particular, in the first 10 years of my practice, I think I saw one 20-year-old with breast cancer. Now it'll happen once or twice a year. 30s used to be shocking, and now, regrettably, it's something that I'll see once every month or two.
Do you think women really realize that this disease is really happening so often and all year long? And do you think they're educated enough about the warning signs and prevention?
Well, I think it's critical that everyone knows their risk. Not everyone has the same risk for cancer, and it's complicated. It's much more than just heredity. Yes, if there's a strong family history of breast cancer in your family, then it's imperative that ideally the person who had breast cancer get genetic testing. And if a mutation is found which predisposed them to breast cancer, then all of their relatives need to get tested as well. But cancer risk, and breast cancer risk in particular, goes well beyond genetics.
Can you elaborate on that? Because someone like myself who had dense breast and had no idea that that was a risk factor, and thinking that I had small breast and no family history, that this could be happening to me, how?
Well, cancer is predominantly an environmental disease. Yes, there's a subset of patients who do get cancer because they inherited a predisposition to cancer. But having a predisposition to cancer doesn't mean you're going to get the cancer. And conversely, having no hereditary risk of cancer that's identified doesn't make you immune to getting cancer. It is predominantly an environmental disease. It's a disease where we can make associations, but we don't directly know the cause of breast cancer. We just know that it's on the rise and that it's linked to different risks, such as high fat diet, obesity, alcoholism. There are environmental factors that do increase your risk.
What about stress?
Absolutely. Absolutely. Stress is definitely a risk factor.
Does the body just react and that's why the cells go awry from the stress?
I don't think we really understand it on a molecular level, but just anecdotally, how many people have you spoken to as you've crossed the United States and crossed the world? And how many people told you that their cancer developed after a stressful experience in their life? Yes, that there has to be a link. And whether it's our immune system, we don't have all the answers, but we can associate cancer with stress.
Do you think that when a woman is diagnosed, she has first of all, does she have the emotional capacity to truly understand what's happening to her and digest the terminology and the all the new things that are happening to her? It's a whirlwind, is basically what I'm saying.
Definitely, definitely. And you know, this is something that I see very commonly in my practice, where you get overwhelmed, understandably overwhelmed, with the diagnosis of breast cancer. And At the same time, we're trying to get people the information that they need to make the decisions that they have to make to move forward with their treatment. And in some ways, it's unfair because we're piling on so much information in such a short amount of time. And what I often tell people is that it's like someone delivered an elephant at your doorstep. And how do you eat an elephant? One bite at a time. And people sometimes are just overwhelmed and sometimes even paralyzed with making decisions because there's so much to go through.
Well, we change that. So that's one of the reasons why I started Learn Look Locate, to intertwine with the medical community, to make them realize that this is just information overload and an emotional stress on top of everything else. What can we do together, patient and the medical community, to really, I'm 4 years out, so I can see it more clearly now. But when this hit me, I was, like screaming, take me to the cancer center, like get this out of me. Like, we can't process it. What can we do different, from your perspective?
Well, not everyone's the same, and not every cancer is the same. Some treatment plans are very simple, and people can grasp that with a simple visit, a 1 hour visit in my office. And I have, I'd say, at least 50%, if not 75% of my patients after a 1 hour visit, based upon their screen detected early cancer, they're able to process the information in order to make the decision to go forward. But not every cancer is that simple and straightforward. And it's like working on a puzzle. We need a certain amount of puzzle pieces in order for there to be clarity about what that perfect plan is for you. And that means not pushing. That means that, I know some cancer patients hate to hear this, but sometimes it's better to slow down rather than to feel that there's a ticking time bomb. And we'll get everything done in a timely manner, but you can't be rash with some decisions, and you need information to make the best decision. Sometimes that means that we need to do genetic testing. That'll take a couple of weeks for the results to get back. Sometimes we need to do an MRI. That can take a week or two. Sometimes it would be beneficial to meet with a reconstructive surgeon. That can take a week or two. There's a lot that goes into making that perfect plan. And I do believe that for every patient, there is a perfect plan, but you have to give it the time to gather the information to make the best decisions sometimes.
But as a patient who's gone through this, how are we supposed to process the anxiety of time, knowing that cancer has been found in our body?
Because you have to, first of all, recognize that not all cancers are alike, and many breast cancers in particular are slow growing. And waiting a month or two to come up with a perfect plan will almost never impact your overall outcome. Yes, viscerally, emotionally, if you have a cancer in you, you want it out. Who wouldn't? But sometimes the best way to treat a breast cancer is to treat systemically before locally, treat the body before the breast. About 20% of my patients receive neoadjuvant treatment, meaning they're getting chemotherapy or endocrine therapy before their surgery. It could be 4 months, 6 months, or even a year before they have surgery. And sometimes that's the best way to treat their cancer.
Hmm.
So you have to move away from that visceral, I want it out reaction. And similarly, for some people, their initial visceral response is to have a double mastectomy. Some people feel like the best treatment for their cancer is to do a double mastectomy. And now, sometimes that is the best choice, but people need to understand that the survival rate is not dependent upon the operation. It's dependent upon what's going on in your body. It's dependent upon the presence or absence of systemic disease and our ability to eradicate the systemic disease. whether we do a lumpectomy or whether we do a mastectomy, the survival rates are the same. And in fact, if you look at the statistics, the survival rates are actually slightly higher with women who have lumpectomies rather than mastectomies. So we have to push back on our emotional responses sometimes when our initial response might be to just get it out and to do the biggest operation possible to get it out. Bigger is not better. Bigger is just bigger.
Yeah. How about, do you think women are empowered to understand and ask the questions that are necessary right before treatment? For instance, if I hadn't had a friend tell me about the oncotype test, I never would have asked my breast surgeon, and I never would have known. This is all foreign. So I guess I wonder from your perspective, should patients be reading about this and understanding what to ask their breast surgeon? And then I ask, why isn't some of this just offered automatically? Because patients want to know, at least I did right out of the gate, do I need chemo? And to know that there's actually tests out there that can help guide that type of treatment is very powerful to anyone smacked with this. So I asked the question, what would you want to empower women with when they meet with their surgeon? Because some surgeons are not bringing this up, or I don't know.
Well, the best patient is an empowered patient. And the best way to be empowered is to have the knowledge that you need to make the decisions on how best to treat your cancer. My best outcomes come from people who own their disease and take active steps in the decisions that they have to make. And you have to trust your gut. There are so many outstanding physicians out there treating cancer now, thankfully. And if you feel like you didn't get the information that you need, you just have to trust your gut sometimes, then you need a second opinion. It's much more important to get a second opinion than it is to rush into something feeling that you may not have all of the information. I can tell you it's impossible to get the information that you need in less than an hour. And sometimes it takes an hour and 15 minutes or an hour and a half, depending upon the complexity of the case. And sometimes it takes a second visit. And it also takes a lot of extra phone calls with each result that returns. Surgery is easy. Communication is really the most important part of our job. And if you feel that you don't have a good communicating relationship with your surgeon, to me, that's a red flag.
It's beautiful to hear you say this, because I do believe some of the cancer centers are so incredibly busy that getting that moment in time with your surgeon or oncologist, at least for me, it was very difficult, and you feel rushed and you got to go, and then you're left with all of this. So it's really nice to know that you understand the communication part of what goes on with patients.
But Cynthia, you have to listen to your words. You felt rushed. That's a cue. That's what people should hear out of this conversation. You shouldn't feel rushed. If you feel rushed, either rushed to make a decision, or if the medical team that's caring for you is making you feel rushed, okay, that's a red flag. And you should never go into this alone. Never. And thankfully, most of the patients that I work with come see me with a wingman or a wing woman. More better, okay? You want people who are close to you to be your second pair of ears. You want their advice. Ideally, someone who can be objective, because we all process information differently. And I give so much information in such a short amount of time, it's impossible to hear 100%. And having that person with you can help reinforce some of that information. I also take notes for my patients. So when I'm explaining to them the different options that they have, to me, it's critical that we have something written down, something concrete. I make a to do list for them. And to me, that's a real important part, not just so that they have something that they can follow, but so that after the fact, I know that I've had that communication with them. And I noticed this really early on in my professional career. With rare exception, if a woman has a lumpectomy, they're going to need radiation therapy. And I found time and time after surgery, and I would tell people the outcome of their surgery, and then they would say, "What's the next step?" And I would say, "Radiation therapy." And they'd be surprised. And I knew each time I had spoken to them about radiation therapy. Well, it didn't take me long to figure out I wasn't communicating right. Because if it happened that often, you know, maybe I'm not emphasizing it enough. And so, that's how you learn how to communicate. It's trial and error. And it's so critical to be repetitive as well, because people sometimes don't catch things the first time. So have a wingman, record the conversation, take notes, make a to do list, try to be as thorough as possible, because it really is very often very straightforward. It's just new to you. And when something's new and you're feeling your heart racing because you've just heard the word cancer, you just need to slow it down sometimes just to make sure that you're making the right decisions for yourself.
Wow, this is incredible. I mean, it's wonderful to hear this. It's really special. It's wonderful so that other people know that they should be getting this type of communication and time allotted when diagnosed, so that they can process all of this, the
If
emotional
if
side. Mhm.
if you don't understand something, then you have to stop and ask the questions that you need answered. It's never okay to just move on if you don't understand something.
Thank you for that. And let me pivot here on just the treatment and where breast cancer in the industry is going, as far as just the incredible things that are happening, and how many more women are really, we don't love the word, but thriving, doing well. I'm almost 4 years out. I think we hear the word cancer and we think we're going to die. So I think it's a good topic so that anyone who's newly diagnosed that's listening to this can hear that, what is that? What is this what is breast cancer? It is treatable. You talk about, I'm not sure if the word is curable. I don't want to speak out of turn here, but really understanding that women are doing well and that we need to celebrate that there is some hope. Um, and that's, part of why I do things the way I do, to give that, share smiling faces. There's a lot of beautiful advocacy work. Can you give them hope that it's going to be okay? What would your thoughts be on a newly diagnosed person, especially with the advances being made in the breast cancer world today?
Well, absolutely, Cynthia. I struggle with the fact that we're just not very good at prevention, but we're really very good at treatment. And the reality is that a woman diagnosed with breast cancer in 2023 will far more likely survive that cancer than not. And we can fine tune that based upon the molecular features of the tumor and the findings at surgery. And thankfully, for many, many breast cancer patients, we can offer them a tremendous amount of hope that they're going to be cured of their cancer. Of course, that's not everyone's story. And you have to live with that cloud of cancer hanging over you after treatment. But overall, our survival rates have been rising for the 25 plus years that I've been practicing, they keep going up. So yes, there's a tremendous amount of hope that we can give. And what I like to focus on with my patients is, there are things that are outside of your control, but there's things within your control as well. And we all know that you can modify things in your life to reduce your risk of cancer coming back. Let's keep it very straightforward. If you've had breast cancer and you've had a lumpectomy, you're at risk of developing a second unrelated breast cancer. So, of course, we're going to have to do closer surveillance for you than we did before your diagnosis. This might include supplemental imaging if you have dense breasts, such as screening ultrasound, contrast enhanced mammography, molecular breast imaging, MRI. There's other tests that we can do beyond mammograms if you're at risk for a second breast cancer, which of course you are if you've had breast cancer once. But beyond that, beyond the science, and before we leave the science, there's endocrine therapy. And Cynthia, I know that that's a difficult conversation for many patients because taking tamoxifen or taking an aromatase inhibitor often comes with side effects that detrimentally affect your quality of life. And I would just ask that you try. That's all we can ask, is that you try. We're learning more about pharmacogenomics. We're learning more to understand why 10 people can take the same drug and have 10 different responses. And hopefully we can make headway on having people tolerate these medications better. But taking that pill can have a significant impact on reducing your risk for cancer coming back. Not just developing a second unrelated cancer, but that theoretical systemic disease could be eradicated by endocrine therapy. So please don't discount the power of that pill. But let's go beyond the science now, and let's talk about the things that we can do to lower our risk of cancer returning. Simple things like stress reduction. I'm joking, that's not so simple. But stress reduction, eating right. I'm okay. I'm on a little bit of a vegan bend here. I've been on a whole food plant-based diet for the past month. I decided that if I was going to start recommending these for patients, I needed to see how easy it was to do. And I am in no way an expert on nutrition, and I am in no way an expert on doing this after only 1 month. But I will say that that's something that you can do. Maybe not, it doesn't mean taking all meat out of your diet, just limiting red meat, limiting the processed foods that we know are bad for us, reducing your alcohol intake. We know that's a carcinogen. Alcohol is a carcinogen. Including exercise in your weekly regimen. These are all things that all of us can do, not just cancer survivors, but the statistic is real. 40% of people in the United States will get cancer in their lifetime. No one is immune. And we can do anti-cancer living that can have an impact on that.
This is incredible. Oh my gosh. And it's really helpful for all of us to hear this, because we need to, it's not just one and done. I myself, you really need to work on not living the way I used to live, and it's very hard. We're all wired a certain way. And, just to slow down and realize maybe the cancer was a big wake up call to take the stress out, right?
Cindy, I've seen it time and time again, where people end up healthier after their cancer diagnosis. And it's regrettable that it has to come to that, that type of wake up call. But of course, you know, being diagnosed with cancer is an invitation to a club that no one wants to be a member of. But let's face it, it's not a very exclusive club these days. Who knows people that have been diagnosed with cancer in the past 5 to 10 years? Who doesn't?
Right.
And
Right.
I mean, think about that. It's estimated that half of all men in the United States will be diagnosed with cancer, and over a third of all women will be. So it's not just breast
Wow.
cancer. Yeah.
Wow. I did not know that. So, Dr. Rosen, there's a lot of advances being made with blood and blood biopsies and what that can tell you, our breast surgeons, about what's going to happen to us. I feel, as someone who continues to go for my ongoing visits, they keep taking my blood. Well, why are they taking my blood? Well, to see if I'm okay. But now we have tests that can actually determine whether or not we're going to have a reoccurrence. And to me, I find this is empowering and powerful. Can you tell us a little bit about what the blood biopsy is all about and what this can do to help a patient monitor the risk of reoccurrence?
Uh, Great question, Cynthia. It's monitoring risk of recurrence. So what do? When someone has been treated for cancer, we follow them for breast cancer in particular. Has the cancer come back elsewhere in the body? And the reality is that prior to circulating tumor DNA testing, we had no test that was effective at identifying systemic recurrence. Sure, we have tests. We have CAT scans, we have bone scans, we have PET scans. But study after study after study has shown that getting those tests routinely are no more effective for diagnosing and treating systemic recurrence than just waiting for someone to develop symptoms.
Mm.
And therefore, it is not recommended that we do those tests routinely. However, we now have a blood test, Signatera, and there are other companies that are releasing similar tests in the very near future that can identify the most minute amounts of your specific breast cancer in your bloodstream before treatment. And then hopefully what we'll find is that after treatment, we can no longer detect that in your bloodstream.
You
And
do it
then going
before and
forward,
after. Sorry to interrupt, but you do it before and after. Is that
it's
right?
critical to do it before and after, because sometimes you just won't notice it in the bloodstream before, in which case it doesn't, it's not really going to be effective after if you couldn't find it before.
Right.
But if you can find circulating tumor DNA unique to your breast cancer in your bloodstream before your treatment, and then after treatment, you want to make sure it goes to zero. Because if it doesn't go to zero, it likely means that you will recur. Thankfully, we can get it to zero most of the time. And if you're at zero, now we have a blood test for the rest of your life that can determine if cancer has come back. And what the preliminary studies show is that we will identify that systemic recurrence 6, 12, maybe even 18 months earlier than when your symptoms would develop. And what our hope is that, is there a tipping point when it comes to systemic disease where the least amount of disease may lead to a chance for a cure, even with systemic recurrence? And those are questions that we don't have answers for yet. But you have to believe that the sooner you find out about systemic recurrence, the better your chances of treating it. So I think this is a remarkable test. I think this is a game changer.
And I, as a patient, agree with you. However, I will tell you, on social media, there's a lot of pushback and I'd love to share that with you if you want to talk about it. Oh, well, what do I do if I find out? And then some doctors don't want to do it because they don't know enough. So the fact that you're so cutting edge is really special, because at least those that want to know can ask for it. But it's the
Well,
what if. Mhm.
well, I mean, we had the same argument about genetic testing too. You know,
Mhm.
the
Mhm.
it does it feel better to know that cancer is coming back with this test if there's a chance that you may not be able to impact that? I mean, I think that's a question. We don't know. And I respect my oncology colleagues that are hesitant to order this test, because what they're fearful of is that, what if you don't get to zero? What if you complete your treatment and you still have circulating tumor DNA in your bloodstream? We don't have years and years of data, but we do have some data. And what that data tells us is, regrettably, that person will recur without further treatment. So that's a perfect scenario for a clinical trial. And there are clinical trials underway right now treating those people who haven't gotten to zero. So I find value in knowing that. Likewise, what am I going to do if I have a patient who has circulating tumor DNA in their bloodstream a year or 2 or 3 or 4 years after their diagnosis? Well, then I'm going to do the imaging test that otherwise I wouldn't do.
Mm.
So maybe that PET scan or the CAT scan or the bone scan would be advantageous at that point. What I ultimately believe is that the ctDNA results are going to guide our therapy. We've seen this with colon cancer. The same tests are available for colon cancer patients. And we're seeing a very similar pattern develop with breast that we learned with colon. I am confident that for some breast cancer patients, not all, this is going to guide therapy.
Wow. Who should do this? The breast surgeon, because that's what you, or the oncologist? Who do we ask? Or can both?
Well, the patients that I currently use the test for are the patients who are most likely to have circulating tumor DNA in their bloodstream at diagnosis. And these tend to be the people who are going to get neoadjuvant chemotherapy, the people who are going to be getting chemotherapy before surgery. That, to me, is the best candidate for circulating tumor DNA testing. So your conversation typically starts with the surgeon and then moves to the medical oncologist. It's not important who orders the test. It's important that the test is offered.
Offered, or do we ask for it?
Please, the latter. If a
We ask
patient
for it.
if a patient is going to be receiving chemotherapy before surgery, then I would definitely ask about the test with both your surgeon and your medical oncologist.
Wow. Just wow.
Mhm.
This is wonderful. Empower us, please. Let's move on to personalized risk and knowing your risk. And this is a hot one for me, and honestly, why I started Learn, Look, Locate, because I felt I had no risk and never in my wildest dreams thought I would get breast cancer. Until this day, I am still in shock. And that is kind of why I want to wake the world up with the way that I do what I do. And with your help, thank you so much. We are working together to make women realize that this can happen, and help me to discuss and bring to the forefront a person's personalized, not only their personalized risk, but also even if they feel, and I've learned this, I think it's 85% of women have no family history. Is that correct? I think that's the right figure. I mean,
Yes.
that's a lot of us. So there's a problem here. And knowing your personalized risk is one way, but also just knowing, because you have no history, is, a wake-up call for the world.
Well, let's look at how we're doing in the United States. Okay, we have a robust screening program in the United States, and what we recommend, the United States, the USPSTF, the United States Preventive Task Force, uh, recommends mammograms every 2 years, beginning at age 50, as a category B recommendation category C recommendation to start in your 40s. The American Cancer Society, the American College of Radiology, the American Society of Breast Surgeons all recommend mammograms beginning in your 40s. And I don't know a single breast surgeon in the United States who doesn't advocate for that. So if you're starting your mammograms at age 40 and getting it every 1 to 2 years, well, what's happening in the United States is that about 60% of our breast cancers are being diagnosed by screen, and about 40% are being diagnosed when symptoms develop. So are we doing a good job screening? I'd say there's a pretty significant opportunity for improvement there. We can do a lot better than 60%.
Mhm.
Well, how do we do a better job? Well, we have supplemental imaging that is more sensitive for breast cancer than mammography alone. It doesn't
Mhm.
replace a mammogram, but when done in addition to a mammogram, will detect more cancers. Something
Mhm.
as simple as a screening ultrasound, contrast enhanced mammography, molecular breast imaging, MRI. These are all tests that can be offered that will sometimes double or even triple your cancer detection rate beyond a simple mammogram.
Mhm.
Well, we can't afford to do that for every patient. It's just too cost prohibitive.
Right, right,
But
right, right.
we can identify people who are at higher risk for breast cancer, and we can personalize their screening plan based upon that risk. Well, how can we do that? Well, most breast centers, and maybe not most, I don't know if that's true. Many breast centers in the United States will ask women 5 minutes worth of questions when they come to the breast center, and they'll then calculate a risk for cancer. And the most popular one is called the thyroacusic, or TC. And in fact, if you look at in your mammogram, some mammograms include the TC score. Anyone who hears this, please go to whoever orders your mammogram, whether it's your primary care doctor or your OB-GYN, uh, ask what your TC score is. Or if you really want to be motivated, go online and Google that. And this is a free test that's available online. It's a risk calculator, and you can calculate your short term and lifetime risk of breast cancer. If we find that you have a lifetime risk greater than 20%, then you qualify for annual MRI. So you have to know your risk, and then you have to act upon that risk. And you should have that information. If you can't get it from your doctor, get it for yourself online and ask your doctor what to do with that.
You bring up I think women just being more empowered about this annual test, a mammogram that we treat so lightly is so serious. I mean, that's another reason why I started this. I mean, it's just not an annual thing. It's something we need to really know more. We need to understand breast density. We need to understand what's our density score. We need to understand this particular test that you talked about. And then, the whole genetic testing. I mean, the first time I've ever been asked about genetic testing was when I moved here to Arizona, and my new gynecologist had a whole list, with genetic testing questions, and I couldn't believe it. So the prevention side, as you always say, and I agree with you wholeheartedly, is really very sad. And so waking the world up to recognize that we can, empower ourselves to get ahead of this disease a little bit, at least by educating ourselves with what you just said. So I just want to steal you for one more question, if that's okay. We talked about one size fits one is a big, kind of a big term that you use a lot. And I think it's really special because it really gives me even the sense, just hearing it, as an individualized way of caring for a person and their cancer. I personally believe that there's a lot of we do this, we do that, we do this, and it just goes on, and we kind of treat the person the same. I've seen it, you hear about it. Let's talk about your philosophy on one size fits one, and any closing remarks you might have about helping women be more educated about their breast health at the end.
Well, precision medicine is all about designing prevention, screening, diagnosis, and treatment plans around the patient. It's another way of saying patient-centered care. Applying universal rules to a heterogeneous group of people just doesn't make sense. One size never fits all. On the screening end, we've talked about how you can personalize your screening based upon your risk. And so what I have a strong appeal to anyone who hears this: know your risk. We have risk calculators for breast cancer that we don't have for other cancers. They're available online for you. Know your risk of cancer. And that way we can create a precision screening strategy for you. Should you be diagnosed with breast cancer, of course, we have to create a precision plan for you based upon the unique biology of your tumor, based upon the anatomy of your tumor, and based upon your anatomy. Everyone comes in different sizes and shapes. And then the third part of that perfect plan for precision is your preferences. Yes, for some people, a lumpectomy is the perfect choice. For other people, it's a mastectomy. Some want a reconstruction. Some don't want a reconstruction. Some want implant-based. Some will avoid implant-based reconstruction like the plague. These are all very personalized decisions, and you really have to understand all of the different variables to come up with that personalized precision plan. And then once you get beyond treatment and you're at your surveillance, likewise, you need a precision surveillance plan. What imaging is going to be done and how often? What can you proactively do in your life to reduce your risks? What can you own? What are you going to change about your life? You have to look back at your life. Of course, no one deserves cancer. No one deserves cancer. There's no blame. There should never be blame. But are there things that we can do to tilt the scale to your benefit? Own that. There's always something that we can do to help you, and always something that you can do. It might not prevent disease, but maybe it'll tilt the scales enough to make a difference.
Really, really powerful. Thank you, Dr. Rosen. Thank you for being the senior medical advisor for this much needed global movement of Learn, Look, Locate. Your compassion towards helping to bridge this much needed gap is so appreciated, not just by me, but the whole breast cancer community, and for taking the time to really understand how desperately we need to connect with the medical professionals to bring this disease to the forefront so we understand and are more empowered about prevention, diagnosis, survivorship, and all the incredible things that are happening. So thank you so much for recognizing that and for being a part of this. It's really an honor, and really appreciate it.
And Cynthia, as I've learned more and more beyond breast cancer to cancer in general,
Sure.
We're lucky with breast cancer. We have risk calculators for breast cancer. We have screening tests for breast cancer. Do you know what percent of cancers in the United States are diagnosed by screening rather than only when symptoms develop?
No idea.
A recent publication estimates that only 14% of cancers diagnosed in the United States are diagnosed by screening tests.
Wow.
Think about that for a second. How much effort and time and money that we're putting into cancer screening, and yet almost 85% of all cancers are only detected after symptoms develop. And as you might imagine, our survival rates go down when cancers are diagnosed when symptoms develop substantially.
Mm,
So we have a problem. We're not adequately using the screening tests that we have available.
mm.
And a bigger problem is many of the cancers that we treat occur in people who don't meet criteria for screening, or we don't even have a screening test. So you really have to understand the fact that cancer screening is critical and you are empowered. There's the cancers that we screen for now are cervical cancer, colorectal cancer, breast cancer, lung cancer, to a certain extent, prostate cancer and melanoma. You
Colon?
really need colorectal. I'm sorry. Yes.
Yeah, yeah, sure.
Breast, cervical, colon, lung,
Mhm,
prostate. Those are the big five.
mhm,
So
mhm.
uh, nothing happens in a vacuum. We do know that women diagnosed with breast cancer are at a higher risk for secondary cancers. So know your risk. It's not just, well, statistically, yeah. So it's not just breast cancer. Know your risks for all cancer.
Yeah. Well,
On that happy note,
oh, thank you, Dr. Rosen, for this amazing hour of your time, and more to come from Dr. Rosen, my senior medical advisor.